Alright guys, this lecture will focus on adrenergic agonists. The next couple lectures are all about adrenergic drugs. So what we mean by adrenergic drugs are just drugs that bind to adrenergic receptors. Adrenergic receptors are the receptors that are stimulated by either epinephrine or norepinephrine. Remember, epinephrine is also called adrenaline, right? Adrenaline and noradrenaline. So that's why the receptors are called adrenergic, because adrenaline or epinephrine binds to them. The adrenergic drugs can be separated into agonists and antagonists. So sympathomimetics mimic the natural ligand binding. So these are drugs that activate adrenergic receptors or mimic the response of the adrenergic system. Technically, sympathomimetics or agonists come in two types. We have direct acting agonists and indirect acting agonists. Direct acting agonists bind to the adrenergic receptor and activate it. So like they're acting exactly like the epinephrine or norepinephrine would act. Indirect acting agonists are still stimulating the sympathetic system, right? They're still stimulating that same response that epi or norepi would stimulate, but they're not binding to the actual receptor. Instead, they could enhance the release of norepinephrine, so there's more natural norepinephrine there, or they could block the reuptake of norepinephrine. So again, there still ends up being more norepinephrine in that cleft. Both of these mimic the sympathetic nervous system response. Sympatholytics are the opposite. Sympatholytics are drugs that block the activation of the adrenal receptors, or adrenergic receptors, sorry. Again, this lecture is going to focus on the sympathomimetics. This lecture is all about the adrenergic agonists. We'll talk about both direct and indirect. Here you guys can see the synthesis and neurotransmission of norepinephrine. And this is just like what we saw with acetylcholine, right? When we looked at the cholinergic neuron. It's just now the neurotransmitter is norepinephrine instead of acetylcholine. But you can see the steps here just to kind of like get your bearings first. This here in pink is the presynaptic neuron. That's the adrenergic neuron that's going to be releasing the norepinephrine. Then here you see the cleft, the synaptic cleft, the little gap between the neuron and the postsynaptic cell. Then down here you see the postsynaptic cell. This is the cell that the norepinephrine is going to go have an effect on. So up here in our presynaptic neuron, you can see the synthesis of norepinephrine. So up at step 1, tyrosine gets transported into the neuron, and it gets hydroxylated or turned into DOPA by an enzyme called tyrosine hydroxylase. Okay, so tyrosine hydroxylase is responsible for hydroxylating tyrosine into DOPA. DOPA, right, this second step, DOPA is then converted into dopamine. So in the synthesis of norepinephrine, we first make dopamine, which is another neurotransmitter. So dopamine then gets picked up or transported into a vesicle, and inside that vesicle, it gets converted into norepinephrine. There's an enzyme called dopamine beta hydroxylase. But the dopamine gets converted into norepinephrine inside of that vesicle. The transport of dopamine into the vesicle is blocked by a drug called reserpine. Reserpine is a drug that was made for hypertension. So if the dopamine doesn't actually get put into the vesicle, then it would just get broken down. So the reason it's stored in the vesicle is to protect it from degradation, like protect it from getting broken down. Also, if it doesn't go into the vesicle, then it's never going to get converted into norepinephrine. So you're not going to have as much norepinephrine. Anyhow, so then now we have our norepinephrine stored in the vesicles. Next, for number 3, you can see the release of norepinephrine. So when the neuron is stimulated and action potential comes down the axon, gets to the synaptic terminal, that opens up voltage-gated calcium channels. You can see right here, calcium enters into the neuron, and that calcium is what causes the release of norepinephrine. Another drug for hypertension is guanethidine. Guanethidine, for example, blocks this release of norepinephrine. So if you're not releasing norepinephrine, you're not stimulating things like heart rate, vasoconstriction, etc. So that would lower blood pressure. Finally, here in the cleft, now we see our norepinephrine. Our norepinephrine is going to bind to receptors. Now, there are actually 2 different places where it can bind to receptors, and the effects are different. So first off, here you can see norepinephrine binding to receptors on the effector cell. That causes, right, like whatever the effect is, depending on the cell. But here, notice there's also receptors on the presynaptic membrane. So the neuron that released that norepinephrine has receptors that the norepinephrine can bind to. Those actually modulate the release of norepinephrine. So if there's enough norepinephrine floating around that it's binding to these presynaptic receptors, that actually decreases the release of norepinephrine because there's already enough in the cleft, you don't need to release any more. So that receptor is actually a modulator. Finally, for 5, you can see the removal of norepinephrine. The norepinephrine in the cleft can do numerous different things. It can bind to receptors. It can diffuse away out of the area. It can be broken down. We have enzymes that are present there in the cleft that can break that norepinephrine down. Or norepinephrine can be retaken up into the presynaptic neuron. And that's what it looks like number 5, I believe. Oh, actually, I don't know if it's number 5 or number 6. Sorry, I can't see, the numbers are too small. But it can actually be, taken back up into the presynaptic neuron. TCAs, TCA is tricyclic antidepressant. So drugs like imipramine, or SNRIs, serotonin norepinephrine reuptake inhibitors like duloxetine, as well as cocaine, all block the reuptake of norepinephrine. The reuptake of norepinephrine is the primary way that we get rid of the norepinephrine, right? So the most efficient way, the best way that we get rid of the norepinephrine out of the cleft is we reuptake, right? We take it back up into the presynaptic neuron. So drugs that block that are going to greatly increase the amount of norepinephrine that's present in that cleft. So sorry, that was 5. 6 is showing us metabolism. Again, norepinephrine can be metabolized by enzymes. There's an enzyme called COMT that's present in the cleft that can break down the norepinephrine in the synaptic cleft. Also, once we take the norepinephrine back up into the presynaptic neuron, once reuptake occurs, we can break it down inside the neuron with an enzyme called MAO, monoamine oxidase. Okay, so monoamine oxidase, MAO, is an enzyme that breaks down the norepinephrine inside the neuron. We also have, they're old drugs, but called MAOIs, monoamine oxidase inhibitors, that inhibit that process, which would increase the amount of neurotransmitter available. Okay, adrenergic receptors. So we just saw how the norepinephrine gets released. The norepinephrine, or if we're talking about epinephrine that's present in the bloodstream, the epi and norepi bind to adrenergic receptors. Adrenergic receptors are divided first off into alpha receptors and beta receptors. Then each of those has multiple subtypes. So like alpha 1, alpha 2. We even get more specific sometimes with like alpha 1A. So we can get really selective sometimes. And then beta receptors, we have beta 1, beta 2, sometimes beta 3. Each of the receptors have structural differences between each other. So like an alpha 1 receptor is structured a little bit different from an alpha 2 receptor. Because of that, they have different binding affinities to different drugs. What this means to us is that we can make a drug that binds preferentially to just one type of receptor. So we have drugs that bind only to beta 2 receptors, or some drugs bind only to beta 1 receptors, which is good because that allows us to target the effects more than having just a drug that binds randomly to all alpha and beta receptors. That would give us all sorts of reactions all over the body, so that's not as useful necessarily. Organs typically have one predominant type of receptor, right? So for example, the vasculature, the vessels in skeletal muscles have some alpha 1 receptors and beta 2 receptors, but beta 2 receptors predominate, right? So that means whatever the physiologic response that happens when beta 2 is stimulated, that's the response you're going to see in skeletal muscles. The heart, on the other hand, has predominantly beta 1 receptors, okay? Other examples, the bronchi, right, leading down into the lungs, has primarily beta 2 receptors. The blood vessels that are just kind of general systemic blood vessels going out to fat, skin, abdominal viscera, etc., have predominantly alpha 1 receptors. Okay? So the reason that this is important is because the physiologic responses that we see are associated with specific receptor types. This is very important, again, because many drugs bind preferentially to one type of receptor. So by knowing what that receptor does, you can figure out what the drug does. We're going to talk about the effects of each receptor in just a second. But for example, you could say binding to beta 2 receptors causes dilation, right? Dilation of muscle, like relaxation of muscle. So, or binding to alpha 1 receptors causes contraction of muscle, right? It squeezes that muscle. We'll talk about why that's important in just a second. One thing that's important to note, chronic exposure to catecholamines is associated with a desensitization over time. Because when you have constant release of epinephrine or norepinephrine, the target cell internalizes receptors, right? It downregulates its receptors to make it less sensitive to that. So chronic exposure to catecholamines does make the patient, desensitized over time. Okay, so let's talk about the different receptors and what happens when we stimulate them. We'll start with alpha receptors. So alpha 1 receptors are very common. When the agonist binds to the alpha 1 receptor, this activates phospholipase C. So alpha 1 activates phospholipase C. This mediates a lot of different effects that are associated with smooth muscle contraction. So if we're talking about our vessels, right, peripheral vessels, this causes vasoconstriction. Ultimately, if we have vasoconstriction in a lot of peripheral vessels, that increases resistance and increases blood pressure. Also in the eye, right? Smooth muscle contraction in the eye causes mydriasis. Also increased contraction of the internal urethral sphincter in the bladder. Okay, all of these are contraction of the muscle, of the smooth muscle, right? Vasoconstriction, mydriasis, increased sphincter tone, etc. Vasoconstriction is the really, really big one there that we see with alpha-1 agonists. Alpha-2 receptors are those receptors that are on the presynaptic neuron. Remember we said we've got the postsynaptic receptor on the effector, but the neuron that releases the norepinephrine also has presynaptic receptors on it. That's the alpha-2 receptor. So when the agonist binds to the alpha-2 receptor, it actually causes inhibition of a neuron, and it decreases cyclic AMP. What that actually does is it decreases the release or modulates the release of the norepinephrine. Norepinephrine binding to alpha-2 receptors on the presynaptic adrenergic neuron, again, modulates, decreases the release of norepinephrine. We do also have alpha-2 receptors on the presynaptic membrane of the cholinergic neuron as well. One thing really quick, when modulating the release of norepinephrine, the receptors, the alpha-2 receptors, are acting as inhibitory autoreceptors. So inhibitory because they're decreasing the release. Autoreceptor, auto means self. So it's like it's decreasing, that norepinephrine is decreasing its own release. When modulating the release of acetylcholine, the alpha-2 receptor is acting as an inhibitory heteroreceptor, right? Still inhibitory, still decreasing the release of acetylcholine, but in this case, heteroreceptor, because it's not decreasing its own release, it's decreasing the release of the acetylcholine. So like overall, the action of alpha-2 activation is to inhibit the release of norepinephrine or acetylcholine. We do also see that alpha-2 activation inhibits the release of insulin. Typically, when we talk about alpha-2, we're talking about it decreasing the release of norepinephrine. Clonidine, for example, clonidine is a blood pressure medicine that's an alpha-2 agonist, which seems weird because stimulating an alpha receptor makes you think that you're stimulating the sympathetic nervous system, right, which would increase blood pressure. But because it's stimulating an alpha-2 receptor, that actually decreases the release of norepinephrine. So that's going to actually lower blood pressure. Each alpha receptor is further subdivided. So for example, alpha-1 has 1A, 1B, 1C, 1D. Alpha-2 has 2A, 2B, and 2C. Most drugs are not this selective. Like we don't go that specific on most drugs, but every once in a while we'll see a drug that like is very selective in its activity. So for example, tamsulosin. Hey, tamsulosin is a selective alpha-1A antagonist. We use it to treat BPH, and it produces less adverse effects than if it was just a regular alpha-1A antagonist. If it was just an alpha-1A, remember alpha-1 causes smooth muscle contraction, right? So blocking alpha-1 would allow for smooth muscle relaxation. In the urinary tract, that's helpful for BPH because it allows for the easier release of urine, right? So the fact that tamsulosin is specific for alpha-1A receptors happen to be highly concentrated in the urinary tract and prostate. So tamsulosin can cause that relaxation in the urinary tract and in the prostate and can make it easier to release urine. alpha-1b receptors, though, those are found in blood vessels. So if we were to block alpha-1b receptors, we would prevent any vasoconstriction in our vessels. Our vessels would actually dilate, and we would have a big decrease in blood pressure. So if we had a non-selective alpha-1 antagonist, and we were trying to treat BPH, our patients would have an adverse drug effect of decreased blood pressure, right? Or possibly like fainting, for example, orthostatic hypotension. But giving tamsulosin that's selective for just alpha-1A allows us to just block the receptors in the urinary tract and not block the receptors in the blood vessels. So we avoid that adverse drug effect of hypotension. So that's alpha receptors. Beta receptors, binding to beta 1, beta 2, or beta 3 receptors results in the activation of adenylyl cyclase and increased intracellular cyclic AMP. The stuff that happens in the actual tissues varies depending on which receptor we're talking about. So beta 1 receptors. Beta 1 receptors, for the most part, are associated with being in the heart. Beta 2 receptors, for the most part, when we're talking about drugs, are associated with being in the bronchi. So the way that I always remember that is, think about in your chest. You have your heart right in the middle, and then you have your lungs on each side. You have one heart and you have 2 lungs. So beta 1 goes in the heart, beta 2 effects are in the lungs. That's the way I always kept it straight. They do other stuff as well, but that's the main thing we normally talk about. So beta 1, when beta 1 receptors are stimulated, it increases heart rate and contractility. So your heart increases cardiac output, it pumps more blood, so you can imagine your blood pressure goes up as well. Also, it increases the release of renin. Remember the renin-angiotensin-aldosterone system? That causes vasoconstriction, that increases blood pressure, so it's like beta 1 really increases blood pressure. Also increased lipolysis, so like breakdown of fats. Beta 2 receptors, tissues that have predominantly beta 2 receptors include the vasculature of skeletal muscles, as well as the bronchi. The tissues with predominantly beta 2 receptors are particularly sensitive to the effects of epinephrine from the adrenal medulla. So just kind of looking at beta 1 versus beta 2, beta 2 binds a little bit better to epinephrine. So remember, epinephrine is coming from the adrenal medulla. Norepinephrine is coming from the neurons actually releasing the norepinephrine. So beta 2 tends to be more sensitive to epinephrine. Beta 1 tends to be more sensitive to both, to epi and norepi the same. When beta 2 receptors are stimulated, we see relaxation. That's like the general thing to keep in mind. Beta 2 receptors cause relaxation of smooth muscle. So this has 2 kind of different effects. Vasodilation. Now, this vasodilation is specifically in the vasculature of skeletal muscles. Because this, and it might seem weird, right? Think about stimulating the sympathetic response causes vasoconstriction in some vessels, and it causes vasodilation in some vessels. That seems weird, right? How can the same exact neurotransmitters cause some vessels to constrict and some vessels to relax? Because different vessels have different receptors in them. So the blood vessels that are going to our skeletal muscles, they need more blood during the sympathetic response. We're thinking fight or flight, right? We're going to run, we're going to be doing something. Our muscles are going to be stimulated. So we need more blood to go to them. So those blood vessels going to our muscles have beta 2 receptors because beta 2 stimulation allows the vessels to relax. The blood vessels that are going to the skin, the fat, the viscera, abdominal viscera, those don't need increased blood flow. And we need that blood, we need blood pressure up so that we can, push the blood through the system to feed our muscles. So those vessels vasoconstrict. Why? Because they have more alpha-1 receptors. Okay, so some vessels have alpha-1, they constrict. Some vessels have beta-2, they dilate. Right? This explains how the same neurotransmitter can cause opposite effects in different vessels. Also, beta-2 receptors increase glycogenolysis in the muscle and liver. This actually becomes important clinically because when we give drugs that stimulate beta-2 receptors, they tend to also increase serum glucose. And this is why. Because you're fueling your body for this sympathetic response. So you're breaking down glycogen to free up glucose so that your cells can use that. And then relaxed uterine smooth muscle. Notice I didn't mention beta-3. Beta-3 receptors are really not as common. They are involved with lipolysis, but the only thing that we really see them for therapeutically is the effects in the detrusor muscle. So we will talk about beta-3 a little bit when we talk about the detrusor muscle, or the bladder. Remember, that's lining the bladder. Okay, so now we'll talk about the actual drugs, right? You know about the receptors, where they are, and what happens when you activate them. Now we'll talk about drugs. We're talking about adrenergic agonists. We're going to start by talking about the direct-acting adrenergic agonists. Direct agonists bind to the adrenergic receptors and activate them, just like the endogenous ligand would. We're going to start by talking about actual epinephrine and norepinephrine. Epinephrine and norepinephrine are like the natural ligands that we make in our body, but we also synthesize these and administer them as drugs. So clinically speaking, typically in the emergency room, we use, or in surgery, we use epinephrine and norepinephrine. So epinephrine is actually one of 4 catecholamines. Catecholamines are like types of neurotransmitters. This is one of 4 catecholamines that we commonly use. I mentioned epi and norepi. We also use dopamine, as well as something called dobutamine. So all 4 of these we'll talk about. So epinephrine. Epinephrine interacts with both alpha and beta receptors. At low doses, the beta effects predominate. So remember, the beta effects are vasodilation via beta-2 receptors. At high doses, the alpha effects predominate. Remember, when we stimulate alpha-1 receptors, it causes vasoconstriction. When we look at epinephrine, the major effects of epinephrine are cardiovascular. We see that by binding to beta-1 receptors on the heart, it increases contractility and heart rate. Increasing heart rate means it's what we call a positive chronotrope. Think chronicity, like chronic, that's time, right? So increasing how many times your heart beats is a positive chronotrope. Increasing the force of contraction, this is called a positive inotrope. So epinephrine is both. It increases heart rate and contractility, which means that it increases cardiac output and blood pressure. It also increases the release of renin, and you guys know that renin leads to the production of angiotensin II, and angiotensin 2 is a potent vasoconstrictor. So, the result of both of these first two things is that we increase blood pressure. Also, we see that we have constriction of vessels going to the skin, the viscera, etc., dilation of vessels going to the muscle and liver. That's kind of typical of what we said for the sympathetic nervous system response. Overall, though, what we see cardiovascularly is increases in systolic blood pressure. And then we can see some decreases in diastolic blood pressure. That increase in systolic blood pressure is because of this increased contractility and increased heart rate, so that increased cardiac output. The decrease in diastolic blood pressure kind of depends on the dose. If we're at a really high dose, then vasoconstriction predominates and we won't see that. But if we're on the lower dose, then the vasodilation predominates, the vasodilation going to the muscles predominates, and we'll see a decrease in diastolic blood pressure. Respiratory effects of epinephrine include bronchodilation. So that's why we use epinephrine when someone's having an anaphylactic reaction, an allergic reaction where they're swelling up. We give them an EpiPen is epinephrine because it causes that bronchodilation. Finally, epinephrine does cause significant hyperglycemia. Remember, I just mentioned on the previous slide that we see increased glycogenolysis. We break down glycogen into glucose. And then also we do have some inhibition of insulin release. So the combination of those two things causes hyperglycemia. That is important to keep in mind if you have a diabetic patient who you've just had to give epinephrine to. You're likely going to have to dose them with insulin as well. So I just kind of led into some of these therapeutic uses, but for the therapeutic uses of epinephrine, epinephrine is the drug of choice in anaphylactic shock, and then we use it for emergency bronchospasm. Again, EpiPen and EpiPen Junior for kids. Regularly, anybody who has anaphylactic allergic reactions, they should carry an EpiPen with them. Epinephrine, as far as the EpiPen goes, it comes in, the EpiPen is an auto-injector, so it's relatively easy to use. It comes in a 0.15 milligram per dose or 0.3 milligram per dose pen. But we tell patients you hold the auto-injector with a fist, right? Hold it in a closed fist and you drive it into the thigh. It goes intramuscular, so you do it in the anterolateral thigh. So like the front and kind of side of the thigh. Hold it in place for somewhere between 3 and 10 seconds to allow all the medicine to go into the muscle, and then you can remove it. Different devices say, 3 seconds, 8 seconds, 10 seconds. So I guess 10 seconds is you're safe no matter what. Also, epinephrine can be used to restore cardiac rhythm in cardiac arrest. So when someone's having a heart attack and their heart is not beating, you can give epinephrine to kind of restart it. Also, epinephrine can be used as an adjuvant to local anesthesia. The reason for this is local anesthesia, so you're just numbing a little local area so that you could do a procedure on it. That anesthetic gets carried away by blood flow. So if you inject an epinephrine into that area, epinephrine will cause vasoconstriction of those vessels. So less blood flow to the area will increase the length of time that anesthetic is there. It also decreases bleeding and it decreases the systemic absorption of the anesthetic. When we look at the kinetics, epinephrine has a very fast onset of action, but a relatively short duration of action because your body is made to clear it quickly. Outpatient, when we use it outpatient for anaphylaxis, again, I mentioned this, it's used IM in the anterior or anterolateral thigh. If we're in the emergency room, we typically will give it IV instead because that's faster. IM's pretty fast, but even if it's just seconds that you're saving, IV is fastest in an emergency. Adverse drug effects of epinephrine include anxiety, just kind of like anxiety, think of the sympathetic nervous system response. People get more alert and kind of aware of what's going on. So it can stimulate some anxiety. Arrhythmias are possible because we're stimulating heart rate. Pulmonary edema is kind of a rare possibility. The kind of really commonly we see hyperglycemia. So again, as I mentioned on the last slide, we give insulin to patients with diabetes mellitus. So if you have a diabetic patient and you've got to give them epinephrine for something, you also give them insulin. There are enhanced effects of epinephrine in patients with, or enhanced adverse drug effects in patients with hyperthyroidism, because hyperthyroidism is already associated with an increased sensitivity to the sympathetic nervous system response. The things that I didn't list here, you guys, that are kind of like obvious for adverse drug effects are things like tachycardia, right? Hypertension, specifically, especially systolic, right? Because that's literally what's happening here. Okay, so norepinephrine and epinephrine are not the exact same. Okay, that's very important when we look at the clinical uses of the two. Norepinephrine, which is given via IV infusion, has primarily alpha activity at therapeutic doses. Okay, epi was alpha and beta. Norepinephrine is primarily alpha activity. This has some important implications clinically. Alpha stimulation causes potent vasoconstriction. So we see increases in blood pressure, both systolic blood pressure and diastolic blood pressure, regardless of the dose, right? So around the clock increase in blood pressure because alpha-1 receptors cause vasoconstriction. Because there's not very much beta-2 stimulation, we don't see dilation of the vessels at all, hence the fact that there's no decrease in diastolic pressure. But also, because there's not much beta-2 stimulation, we don't have bronchodilation. So this is not effective for anaphylaxis or bronchospasm. Okay, very important to keep in mind. Oh, also, sometimes with norepinephrine, not only does it not increase heart rate, it can actually be associated with decreased heart rate sometimes, which seems weird. The decreased heart rate is not a direct effect, it is reflex. So because of the baroreceptor reflex, norepinephrine can actually cause some reflex bradycardia, so we can see decreased heart rate. The baroreceptor reflex, remember, is how we adjust our blood pressure. This causes vasoconstriction, right, which increases pressure. Well, the body says, okay, let me decrease pressure back down to normal, and the way I can do that is by slowing decreasing cardiac output. So I'll slow my heart rate down. So that vasoconstriction and increase in blood pressure can actually cause a decrease in heart rate to try and counteract that increase in blood pressure. Norepinephrine. Norepinephrine is used clinically for shock. The only therapeutic use of norepinephrine is for shock. For example, septic shock, right? So shock is like a a drop in blood pressure. That's what shock is. It's a drop in blood pressure that's so severe it requires vasopressors, right? It requires some support to increase pressure. The reason that this is so effective is because it increases the total peripheral resistance and then increases blood pressure. So the problem is blood pressure went down. Well, we'll give norepinephrine and blood pressure will go back up. There's all different types of shock that this can be used for. It can be used for septic shock. This is what happens when somebody has sepsis, when they have an infection in the blood. Cardiogenic shock. Cardiogenic shock is shock that occurs because of the heart. So like the heart's not pumping enough blood. So that's where the decrease in blood pressure comes from. Also, neurogenic shock. That's still coming from the heart, but it's because of the neuron stimulation of the heart. And then finally, and this is a common one, hemorrhagic shock. Hemorrhagic shock occurs because of a hemorrhage. Or this is also, you could call this hypovolemic. I can't write it, guys. Hypovolemic shock. So you bleed, you lose too much blood, you don't have very much blood volume, so blood pressure plummets. It makes sense that causing vasoconstriction would increase that pressure again. It has similar adverse drug effects to epinephrine. We still have like anxiety. There's some like tremor, arrhythmias are also possible. Pulmonary edema is also possible. Things like headache is present for anything. Also can cause blanching and sloughing of skin along the injection site. Blanching is like when the skin turns white. So the skin turns white or pale rather because the cutaneous vessels constrict. Remember, this is causing vasoconstriction. So right along the injection site, there's a really high concentration of it. So we see a lot of constriction that decreases blood flow to the area. And that can actually cause some damage to the tissue in the area. We can treat that with local alpha antagonists. So like phentolamine, for example, is an alpha antagonist that we can give, just inject locally right to that area, which blocks the response in that little area. Or intradermal terbutaline is another option. Tissue necrosis occurs if the drug extravasates. Extravasation is leakage of the drug out of the vein into the surrounding tissue. So if this happens, if the drug leaks out into the tissue, it causes such constriction and decreased blood flow that that tissue in that area actually dies. That's what necrosis is. So we do not administer norepinephrine in peripheral veins, if possible. So if we can avoid administering it into, peripheral veins, like in the hand or the arm, then we do. Like if there's a central catheter, for example, that is better, or a PICC line. Terbutaline, you guys, is a beta agonist. So it's kind of like the beta agonists cause relaxation, right? So the problem is vasoconstriction, beta agonists cause relaxation. Nitroglycerin, sorry, I didn't mention nitroglycerin can also be used. Nitroglycerin is also a vasodilator. Okay, next, dopamine, right? So we're talking about the catecholamines. We had epinephrine, we had norepinephrine, now dopamine. So dopamine, also given via IV infusion. First off, dopamine binds to dopamine receptors, dopamine 1 and dopamine 2 receptors, but it also binds to alpha and beta receptors. So dopamine binds to alpha 1 receptors and beta 1 receptors. This has stimulatory effects on the heart and causes vasoconstriction. Really at higher doses, it has the alpha. but so it's chronotropic, positive chronotrope and inotrope. So it increases heart rate and increases force of contraction and can cause vasoconstriction. So we see that it increases blood pressure. This vasoconstriction, again, at higher doses. It also binds to dopamine receptors, D1 and D2 receptors, on the mesenteric vessels and renal vessels. This is important because this dilates these blood vessels and increases blood flow to the kidneys and other viscera. This is opposite of norepinephrine. Okay, norepinephrine can decrease blood flow to those other areas, right, because of alpha receptor, because of the vasoconstriction that occurs with the alpha receptors. But because dopamine binds to dopamine receptors, it increases the amount of blood that's going to the kidneys and the viscera. This becomes important. If you increase blood flow going to the kidneys, you're going to increase urine production. So you're going to be getting rid of fluid that way. That is why when you look at the therapeutic uses of dopamine, we can use it for cardiogenic shock and septic shock. We do not use dopamine for any hypovolemic shock. Again, it increases blood pressure by increasing resistance, right? Vasoconstriction, so it increases resistance. And it increases cardiac output, but it does not decrease renal blood flow. It actually increases renal blood flow. So it causes diuresis. It causes us to get rid of fluid. If we are in shock because of a hemorrhage, right? If we're hypovolemic, we don't have enough fluid in the blood. The last thing we want to do is be getting rid of fluid via diuresis. Okay, so we don't use dopamine for hypovolemic shock. Dopamine can be given for hypotension and for severe heart failure. Generally, we don't give agents that stimulate the heart for heart failure because that actually worsens the heart failure. But when a patient is in very, very severe heart failure, kind of at the very end of life, we do give agents like dopamine because they improve the way that the patient feels. Also can use it for bradycardia that's unresponsive to other treatments. So it would not be first-line therapy, but it can be used. Adverse drug effects, nausea, hypertension, arrhythmias. In overdose, if somebody has too much of it, we see effects that are kind of like sympathetic stimulation, but the effects are pretty short-lived. Fenoldopam. Fenoldopam is another direct-acting adrenergic agonist. It's given via IV infusion. Fenoldopam is a D1, dopamine 1 receptor agonist in coronary, renal, and mesenteric vessels. So it causes vasodilation. Okay, binding to this D1 receptor causes vasodilation in arterioles leading to the heart, the kidneys, and the viscera. Mesenteries, the viscera, right? So increased blood flow to the heart, to the kidneys, and to the viscera. This protects those organs from damage that could be caused by severe hypertension. So for example, when patients have severe hypertension, very, very severe hypertension, one of our major concerns is that we're going to end up damaging the organs, right? Their other organs are going to get damaged because of that really, really high pressure. So what we can do, we're obviously we try and lower the blood pressure as well, but in the meantime, we can also give Fenoldopam in order to protect their organs while we're trying to decrease the blood pressure, because it opens up those vessels so that at least the pressure in those organs is not as high. It's given via IV infusion. because it has extensive first-pass metabolism. It only has, just when you give it via IV infusion, it only has like a 10-minute half-life post-infusion. So that's something to keep in mind. Like you have a short, you give it and then you're giving other meds IV typically to try and decrease the blood pressure. But after the infusion, you've only got about 10 more minutes while it's working. Adverse drug effects include headache, flushing. Both of those have to do with vasodilation, opening up of blood vessels. Dizziness, same thing, opening up of blood vessels can cause dizziness. Nausea and vomiting, and tachycardia. That tachycardia is a reflex tachycardia because vasodilation, we can see tachycardia as a response. Dobutamine. Dobutamine is primarily a beta-1 agonist. It has only minor effects at beta-2 receptors and alpha-1 receptors. So it has minor vascular effects. Minor vascular effects. Predominantly, the effects of dobutamine are on the heart. It is a positive chronotrope and positive inotrope. So it increases heart rate and increases the force of contraction. We use it to increase cardiac output in acute heart failure, and for inotropic support post like cardiac surgery, for example. Because again, it's able to increase cardiac output without increasing the oxygen demands of the heart as much as the other agents do. The adverse drug effects include just kind of like epinephrine. Again, increased heart rate, so tachycardia. We can see an effect on blood pressure because of the increase in cardiac output. We can see issues with arrhythmias because we're affecting heart rate. Caution in patients who have AFib, because you don't want to increase the heart rate even more. And just the reason we bring this up now is because sometimes that happens after someone's had, cardiac issues. And then also keep in mind, tolerance does develop, so you can only use it for a short period of time. So for example, like when we're treating heart failure, we can give this to kind of provide cardiac support to increase cardiac output for a short period of time. But really with any of these agents, tolerance is going to develop, so it can't be used long term. Okay, so kind of moving away from cardiac, like emergency agents. All those agents we've talked about thus far are really like emergency agents, either anaphylactic shock or cardiogenic shock, hypovolemic shock, whatever. Now we're kind of moving away from that. Oxymetazoline. Oxymetazoline is an alpha-1 and alpha-2 agonist, so primarily an alpha agonist. The alpha-1 stimulation causes vasoconstriction. That's predominantly what we're seeing with oxymetazoline. We're seeing vasoconstriction. So oxymetazoline is in OTC nasal sprays, over-the-counter nasal sprays, and ophthalmic drops. When you give it via a nasal spray, it causes vasoconstriction in the blood vessels going to the nasal mucosa. So if the vessels in the nose constrict, then you have there's less blood flow, there's less inflammation, so it decongests the area. Ophthalmic drops can be used for redness in the conjunctiva, right? If the blood vessels in the conjunctiva constrict, there's less blood flow, so there's less redness. So used for congestion and for red eye. The adverse drug effects, Um, if it's absorbed, so we use it locally to try and decrease systemic adverse drug effects. But either way, some of the drug is going to get absorbed systemically anyways. So patients, the more they're using it, the more likely it is that they have systemic effects from it. Some patients might not notice anything, but patients might report some nervousness, some insomnia, some headache. So you might want to caution patients the first time they use it, don't use it at bedtime, just to see if it's stimulatory for them or not. Used nasally, it can cause some local irritation, some kind of like drying out and irritation of the nasal mucosa and sneezing. One thing that is super important is when it's used via a nasal spray, use is limited to only 3 days. Patients cannot use it longer than 3 days. So they've got 3 days to try and get their congestion under control, and then they've got to stop using it. If it's used longer, the nasal mucosa actually becomes dependent on it, and when they stop using it, they get severe rebound congestion, even worse than it was to begin with, right? So that doesn't happen if they only use it for a day or two, but any longer than 3 days, then there's a big risk for severe rebound congestion. Okay, phenylephrine. So phenylephrine is another drug that we can use for as a decongestant. We can use it for congestion, but it has multiple uses. So phenylephrine is, again, primarily an alpha-1 agonist. We know that stimulating alpha-1 can cause vasoconstriction. Also, that vasoconstriction can end up increasing blood pressure. Remember, causing systemic vasoconstriction increases diastolic blood pressure and systolic blood pressure. It's only binding to alpha-1 receptors, so we only have that vasoconstriction. We don't have any vasodilation happening in any other areas. So it's just vasoconstriction, so it's increasing both systolic and diastolic blood pressure. It does not have any direct effect on the heart, but remember, the heart has, there are reflexes that occur with heart rate. The heart responds to changes in blood pressure. So if we increase blood pressure, the heart responds by decreasing heart rate. So we can see that it actually can cause bradycardia. It can actually decrease heart rate. So uses. It can be used cardiovascularly. We give it parenterally. It is injected for paradoxical supraventricular tachycardia. Again, the reason for this is it would lower heart rate. It induces a reflex bradycardia. Also can be used for hypotension because it causes vasoconstriction and increases blood pressure. It is particularly helpful for hypotension in hospitalized or surgical patients who have a rapid heart rate, right? So potentially, especially beneficial for hypotension with tachycardia, because it does both. It lowers blood pressure, it increases blood pressure and slows heart rate. Large doses can cause some hypertensive headache and some cardiac abnormalities. More commonly, phenylephrine is used over the counter as a decongestant. Now, phenylephrine is available orally and nasally. The oral formulation is useless, absolutely useless. Sudafed is an effective oral decongestant. When Sudafed was put behind the counter, because it can be used to make methamphetamine, when it was put behind the counter and you've got to get your license out and the pharmacy has to be open in order for you to buy it, the drug companies were like, okay, well, what do we replace it with? What can we put out on the counter to sell directly to patients? Phenylephrine was their response. They put phenylephrine tablets. Phenylephrine by mouth does not have bioavailability that works. It does not get to a high enough bioavailability to do anything. So taking phenylephrine by mouth is just a waste. It doesn't do anything. I've been saying this for like 10 years. The FDA just made an announcement on this, like, I don't know, a month or two ago. So I was like, yay, go me. Anyhow, phenylephrine is also available nasally. It works intranasally. So phenylephrine nasal spray, you're not worried about bioavailability because you're applying it directly to the site of action. So it stimulates alpha-1 receptors that causes vasoconstriction in the nasal mucosa. Less blood flow means less inflammation, so there's less congestion. Okay, Midodrine. So Midodrine is a prodrug. Prodrug, remember, means that like when you give it, it's not active. It has to go through the liver first in order to be activated. It is an alpha-1 agonist that causes vasoconstriction in peripheral vessels. So increased arterial and venous tone. We use it in patients who are experiencing orthostatic hypotension. Orthostatic hypotension is when patients stand up, when they're sitting or laying and they stand up, they get really low blood pressure drops, and sometimes they pass out or faint. Your body should not do this, right? What happens in a normal person is you stand up and all your blood starts to rush to your legs, so your blood vessels constrict, right? Like all of the vessels in the legs constrict, and that pushes the blood back up so that you have enough going to your brain. Some patients don't have this correct vasoconstriction response. So giving Midodrine is something that can cause vasoconstriction so that when they stand up, there's enough blood getting pumped up to their brain. Midodrine is typically dosed TID 3 times a day, generally like every 3 or 4 hours. You don't take it at night. It's not taken at bedtime, because at bedtime, you don't have that problem of all the blood dropping to your legs. So at bedtime, you're laying down, it can actually cause supine hypertension. So you make sure it should not be taken within 4 hours of bedtime. Otherwise, again, patients will have high blood pressure at night when they lay down. Finally, or next, Clonidine. Clonidine is interesting because Clonidine is an alpha-2 agonist that we use to treat hypertension. And again, this seems weird to use an alpha agonist for high blood pressure because you would think that an alpha agonist would increase blood pressure more. But again, it's an alpha-2 agonist. Remember, alpha-2 receptors are presynaptic receptors that decrease the release of norepinephrine. It actually works centrally, so it works up in the brain. Again, central presynaptic receptors are modulators of the release of norepinephrine. So what this does is it decreases sympathetic outflow from the brain. So less sympathetic outflow means less sympathetic stimulation of your cardiovascular system, so blood pressure can decrease. It's not like the first or second drug that we use for hypertension, but sometimes you'll see it added on to patients. Clonidine can also be used for withdrawal symptoms. So patients who are going through, opioid withdrawal or benzodiazepine withdrawal, the reason for this is withdrawal is associated with an increased sympathetic response, right? That fight or flight, like panic response is occurring. So sometimes, giving Clonidine can help with that a little bit. It can decrease heart rate, decrease blood pressure, kind of decrease anxiety and tremors a little bit, and it's completely non-narcotic. Also, Clonidine can be used for ADHD as well. Sometimes we see it used for kind of other diseases like Tourette syndrome, some things that we don't necessarily treat very well. We've kind of tried all different types of drugs for. As far as ADHD, guanfacine is another is another alpha-2 agonist that we could use, for example, for ADHD. Adverse drug effects. Remember, we're decreasing overall sympathetic output from the brain. So lethargy and sedation, because you're not stimulated. Constipation and xerostomia. Remember, alpha-2 receptors also modulate the release of acetylcholine. So some side effects actually look like anticholinergic side effects. Okay, that's why the constipation and the dry mouth. One thing that's very important to keep in mind with clonidine is you have to avoid abrupt discontinuation. If the patient's taking it for withdrawal and they're only taking it for a couple days, that's okay. But if you have a patient who is taking this, for blood pressure or ADHD, and they've been taking it for a considerable amount of time, they cannot stop it abruptly, because all of a sudden there's a big flood of sympathetic stimulation coming out of the brain, and there's really severe rebound hypertension. So patients have to slowly taper off of the medication. Okay, continuing on with direct-acting adrenergic agonists, metoprolol, and more importantly, albuterol. These are what we call short-acting beta agonists. Albuterol is preferred because it's more selective for beta-2 receptors. And this is very important for the way that we use these. So short-acting beta agonists, specific or selective for beta-2 receptors. Remember our beta-1 versus beta-2 conversation. Beta-1 in the heart, beta-2 in the lungs. So stimulating these beta-2 receptors causes smooth muscle relaxation in the bronchi. So bronchodilation dilates the airways to have increased airflow down into the lungs. This is used for acute asthma symptoms. So acute as in like an asthma attack, right? We give patients who have asthma long-term controller medications, but if something happens and they feel like they can't breathe, like they've got bronchoconstriction happening, they can use their albuterol inhaler, and that will cause bronchodilation. Given via inhalation, via what's called a metered dose inhaler. So you just push down on it, inhale, hold it, and then exhale, and that's how the drug gets down into the system. It is also available via a nebulizer solution. So the solution goes into a machine, the machine aerosolizes the drug, the person just sits there and inhales the drug slowly for a longer period of time. When we talk about, or when you guys talk about asthma and COPD next semester, you'll talk about the difference between an inhaler and a nebulizer. Note, there's also a drug called terbutaline. Terbutaline used to be a short-acting beta agonist, but it's not available in the US via inhalation anymore. Injectable terbutaline is used as a uterine relaxant to prevent premature labor. So terbutaline injectable causes uterine relaxation to prevent premature labor. That can only be used for 72 hours though. But we no longer have terbutaline available in the US via inhalation, so just albuterol. Adverse drug effects include tremor, restlessness, and anxiety. We're giving it via inhalation, so there's not as much systemic absorption, but some can still occur, especially depending on how much the patient uses. Sometimes during a severe exacerbation, a patient could be using 6 inhalations, up to 4 to 6 inhalations at a time, which is a lot. Tremor is the most common adverse drug effect. However, patients tend to develop tolerance to this. So if a patient tells you, the albuterol worked great, but I was shaking like crazy afterwards, you can kind of reassure them that will probably go away with time. If we were to give it orally, if the albuterol were given orally, that would introduce the possibility of like cardiovascular effects like tachycardia or arrhythmias. Because I know this is, beta, oh, ouch, got my back. This is beta 2 selective, but no drug is perfectly selective. So you could still have some beta 1 effects. So that's why we give it via inhalation. Salmeterol, formoterol, and aformoterol are what we call LABAs. LABA is long-acting beta agonist. So these do the same things as albuterol, but they do it for a longer period of time. So generally, albuterol is taken every 4 to 6 hours. These agents are generally every 12 hours or even 24. They could be once a day as well. These are also used for the management of respiratory disorders, including asthma or COPD. They are a mainstay of treatment for COPD. When we look at the treatment of asthma, the kind of major component of chronic asthma therapy is an inhaled corticosteroid. So if patients are on LABAs, long-acting beta agonists, they should be used in conjunction with an inhaled corticosteroid. So typically we would start the patient on an inhaled corticosteroid and then albuterol for PRN use as needed. Then if they're not well controlled and they're having a lot of exacerbations, then you can add a LABA. So they would use the long-acting beta agonist and their inhaled corticosteroid every day. And then if they had an exacerbation, they would use their albuterol. I do want to mention, so for the longest time, there was like this huge red flag saying you can never use a LABA alone in a patient with asthma. It has bad outcomes, all this stuff. Like we were like, fear of God was put in us about making sure that patients have an inhaled corticosteroid. Just this past year, there was some evidence that came out and they said that there's actually nothing bad that happens. Like there's no bad outcome that comes from giving patients a LABA without an inhaled corticosteroid. But even though they kind of debunked that claim, they said still practice the same way. So there's no fear about it, but still you should give patients an inhaled corticosteroid and then add the LABA if needed. Again, the difference here with these beta 2 agonists is that one dose lasts over 12 hours. Formoterol and aformoterol have a rapid onset of action. Salmeterol has a delayed onset. Formoterol actually starts working so quickly that it could be used for acute symptoms as well. Again, this hopefully will come up for you guys when you do asthma and COPD, but we typically use albuterol for a controller acute med because it starts working so fast. But formoterol actually does too. So formoterol is good on both sides. It starts working right away and it lasts for a long time. So it's kind of like doubly beneficial. Whereas albuterol, again, generally albuterol, they say, that it works for 4 to 6 hours. Sometimes it's closer to like 3 hours. But, formoterol is at least 12 hours. You could not use salmeterol this way because it takes an hour to work. So if somebody's gasping for air, you're not going to give them something that's not going to work for an hour. Mirabegron. Mirabegron is a beta 3 agonist. We have not spoken much about beta 3, but remember I told you beta 3 is in the bladder. That's really like one of the rare times we talk about beta 3 is when we're talking about the bladder. So mirabegron is a beta 3 agonist that causes relaxation of the detrusor muscle. So it increases bladder capacity, and we use it for overactive bladder. One thing that's important to keep in mind is that one of the adverse drug effects is possible increased blood pressure. Again, like drugs aren't perfect in their selectivity. So mirabegron can cause some increased blood pressure. Because of this, we do not use it in patients with uncontrolled hypertension, okay? So you use it for overactive bladder, but not if your patient has uncontrolled hypertension. If they have hypertension and it's well controlled on another medicine, then that's fine, but not if it's not controlled. Also, it does have a kind of serious drug interaction. Mirabegron can increase levels of a drug called digoxin. Digoxin it's a cardiac drug. We use it for arrhythmias or heart failure. But digoxin is a narrow therapeutic index drug. So remember, that means its toxic level is very close to its therapeutic level. So there's not very much wiggle room with digoxin. So if a patient's on digoxin and you give them mirabegron, that could potentially be very dangerous. Also, mirabegron inhibits CYP2D6. A lot of drugs are metabolized by CYP2D6, so it could increase the effects of them. Metoprolol, which is a cardiac med, a beta blocker, a lot of other beta blockers. A lot of pain meds are metabolized by 2D6, a lot of antipsychotics, a lot. So just keep in mind that you need to look at drug interactions if you start a patient on mirabegron.